TopMedTalk.
Well, welcome to TopMedTalk. We are coming to you today with a roundtable with the Australians about shared decision making. I'm Desiree, your host, and my co-host today is one of the TopMedTalk favorites and father of perioperative medicine himself. I love it, Ross Carriage. Ross, how are you today?
You never fail to embarrass me, Desiree.
I can't stop. I just can't stop, Ross. It's true. That's how people know you.
Anyway, I'm great.
Good.
Always good fun doing these.
It is. Well, Ross, we are coming to our TopMedTalk listeners during live from London, the EBPOM virtual conference, which is very, very exciting. And so we thought we would do some roundtables virtually, which is working out for us pretty well so far, yeah?
Yep. On the other side of the world and different time zones and all that, but it's working.
Yeah, we are making it work. Now it's early morning here and getting late there for you guys in Australia. Now, Ross, you are in Newcastle and you are a anaesthetist there at John Hunter, correct?
Correct.
I'm finally getting it. So for all of our listeners know you, but for our new listeners, can you tell us a little bit more about your background and maybe that father of perioperative medicine title, how that's kind of come about?
Well, that I suppose I was lucky enough to get in with some ideas around perioperative medicine in the late 1980s, based, interestingly, on some work that I did as a registrar in Ealing Hospital in London, which is near where Monty Mython lives. But then when I became a specialist in Australia, I had the chance to roll them out at Liverpool Hospital. That's Liverpool Hospital in Sydney in Australia, which is confusing. And it's gone on from there. And so we're early off the mark in Australia, but lots of other places have caught up and other people had the same ideas. I don't think every good idea has 1,000 fathers. Your failure, of course, is an orphan. So, so it must have been a good idea.
Yeah.
Anyway, let's move on.
Oh, Ross, don't be shy now. Well, lots of contributions over the years, and you've been involved with EBPOM for many years, going to London during the summer for the EBPOM London meeting.
But unfortunately not this year.
I know, it's a real bummer.
But it's been, the EBPOM meeting, it's a great thing doing it virtually, and look at the attendance. It's, I think, 7,500 compared to, 500 last year. So this is going to be the future.
It is, absolutely. Well, Ross, we put together a round table, which you are great at doing. It's a testament to what you've been doing over the years in your own career, bringing different people in and different voices to have to forward practice and what you're doing there. So you put together a great group for us. So Ross, can you give us some introductions and bring everybody in?
Yeah, okay. So 4 colleagues, friends from around Australia. Deborah Leung is an anaesthesiologist in Melbourne at the Peter MacCallum Cancer Centre in Melbourne. The Peter MacCallum, or Peter Mac as it's colloquially called, is arguably Australia's leading medical centre for cancer. It's got close links with MD Anderson in Texas and the Royal Marsden in London. And they're doing some great work down there. And Deborah's been doing some particular work with shared decision-making, which we'll hear more of later. And that's Deborah sitting there in front of a backdrop of one of the scenic spots in Victoria, the Great Ocean Road, which I'm yet to go to.
Wonderful. Deborah, thank you so much for joining us. That is a beautiful shot there.
No worries. Thank you for having me.
Yeah, well, we'll look forward to getting deeper diving into shared decision making for sure. Well, Ross, who else have you brought?
Now, we've got Ashland Flurry, is a geriatrician in Brisbane. Although she's originally from Ireland, as you'll notice from her accent. It's a beautiful accent. All those Irish accents are. And she's a geriatrician, but also has a particular interest in perioperative medicine in the elderly and the perioperative care of the elderly and perioperative delirium. And she's done some great talks for us on that. I think where Ashling works in Brisbane, she deals with a lot of socioeconomically challenged areas in Brisbane. And I think that's some pretty interesting particular things around this topic as well of shared decision making. So,
absolutely. Well, thank you for joining us, Ashling.
Yeah.
Thanks for having me, Desiree.
Yeah, I love I love your background too. Tell us where that is.
So it's just taken from the Miami Hill, looking back over Miami Beach and up to Surfers Paradise at the Gold Coast.
Oh, that's beautiful. That is absolutely beautiful. And that's not Florida coast. That is the Gold Coast in Australia. All right, great.
Yes, the other Miami.
The other Miami, yeah. Well, that's great. Well, we look forward to hearing your perspective for sure.
Yep. And then John Garney is a surgeon. He's a surgical colleague of mine at John Hunter Hospital in Newcastle. He's recently, only about 6 weeks ago, I think, retired as chief of surgery. And he's learning to cook, but he's still doing a lot of teaching and research. And really in the last, 12 months, you've developed a particular interest in shared decision-making ideas, John, and you've done Deborah's training program that we'll hear about later. And John's never short of an opinion, and they're usually good opinions.
Spoken as true colleagues who've been working together for a while. Well, John, thank you so much for joining us. We really appreciate you taking the time.
Thanks for having me.
Yeah, and congratulations on your retirement. That's fantastic news.
Heads the buns.
Yes, absolutely. Well, John, your background there for us. Can you tell us a little bit about your background there? What we're looking at?
So the backdrop is really looking the other way from Ross's. It's an aerial shot of Newcastle.
Yeah, it is.
And trying to promote a rebuild of our John Hunter Hospital that's just being planned at the present time.
Great. All right. Well, looking forward to your perspective as a surgeon for sure. Ross, next.
And then Geriatric is one of my colleagues as an anesthesiologist in Newcastle. You will be too polite to point out that she's younger than me, but I will admit that she is. But Praga is one of my, I've got a lot of smart colleagues, but she's particularly smart. And she's had an interest in shared decision making. She's been working with Deborah, but of particular interest, she's just landed a pretty sizable research grant from the Medical Research Futures Fund to look at research into shared decision making, and that raises some interesting questions as well. So we'll come back to that.
Well, thank you for joining us, Pragya. I really appreciate it. Ross doesn't like to be embarrassed, but he knows how to tease others. Well, Pragya, you are really looking forward to hearing about the research grant that you have coming up, and if you can tell us a little bit more about that later on, I think it'll be fantastic to hear kind of how you're pulling all of these things that we're going to be talking today into some very important research.
Okay, thanks for having me.
Yeah, thank you. All right, well, we'll go ahead and just dive right in. I think the really most important thing that we should start off with is the fact that we need to clarify what we mean by shared decision making. It's a term that's often misunderstood, and it really used in a lot of different ways, depending on who the person is that's speaking. So what their perspective is and what their background is. So Deborah and Ashland, I think that it would be good to hear from you guys first, maybe to tell us, in your own words, what the or in your words, but what the overall overarching idea of shared decision making is. Deb, if you want to start out, that would be great.
Yeah, thanks, Desiree. And thank you for bringing up such an important kind of issue at the beginning, because I think, as we would all agree, shared decision making really is, it can be quite a number of different things. And I think that's probably one of the contentious issues in the literature and the research, which Pragya will probably talk about later on. But there is sort of varying definitions, and part of the issue with studying it is that patients and clinicians both perceive it as potentially quite different things. I don't know, I'm sure Ashling will probably pitch in as well, but the definition that I've kind of often fall back to that I like is the idea of it being sort of an integrative communication process that occurs between both patients and clinicians. And it combines the principles that we take from best scientific evidence and evidence-based medicine, and combines that with patient values and goals as expressed by the patient to come together to form a treatment decision that is congruent with the patient's goals. And it's sort of a very wordy definition, but the reason I kind of like it is because it has a number of different really key sort of words that come up in the definition. And I think there's obviously something about the process being dynamic between the patient and the physician, so it's iterative. There's also something about communication being really important, and the fact that it's a process rather than a single defined temporal point where a decision is made, because we know often, complex decisions happen over a number of encounters between patients and healthcare workers. And then I think the other part of it is that it also acknowledges the two kind of content bits as well, which are the fact that we're bringing together evidence and we're bringing together the patient perspective as well. So that whole idea of combining disease and illness models together. So although it's a lot of words, I think it's a really complex concept. So I think you need a lot of words to be able to define it in a meaningful way.
Yeah, definitely. Well, Ashleen, from your perspective as a geriatrician, would you agree? Do you have anything to add, or would you change that up a bit?
Look, I think the general principle is the right one, and I think Pragya will, like Deb mentioned, will speak a bit more about some of the issues of what other people consider to be. I certainly think that it has to be based on values of the person and what their goal of outcome is. I suppose my concern, I think while we should aim to have it quite evidence-based or evidence-based as much as possible, the reality is that for many older people undergoing surgery, the evidence base isn't actually that strong. And the evidence for harm is actually, you can sometimes get really bogged down in sometimes looking at what the harms of an intervention are versus what the potential benefits are. So I think that we've got a long way to go for evidence, especially around evidence for benefits in older people. But I certainly think as a general definition that, I'm on the same page as Deb.
Yeah, great. And Pragya, I mean, I'm sure that you've, really looked into what is out there in the literature. Can you tell us a little bit, about what you've found?
I guess the main thing is we've heard from Deborah and Eileen about how communication and how understanding patient values is incredibly important, and Deb touched on the iterative process. One of the things that I found overwhelmingly in the literature around shared decision making is people may talk about a decision tool as shared decision making, or so we showed patients a video, and whilst it might be useful as a decision tool, I don't know that it quite falls into that same category as changing how you communicate with a patient to elicit what their values are, what their goals of care are. So I guess that was the main thing that I've really noticed is defining what shared decision making is, hasn't really been consistent in the research that currently exists.
Well, yeah, it seems like that is the case for sure. Well, hopefully we'll have a little bit more clarity and define it and continue to define it through this conversation. So Deb, tell us what you do at Peter Mac. So, developing this interest in shared decision making, because, I'm an anesthesia provider, a nurse anesthetist myself, and it's something that we think a lot about. It's like how we have these conversations about what's right and, is this the right thing to do for the right patient at the right time? But very few people kind of actually dive into this and have a true interest in determining what it is. So how did you kind of get into this?
Well, I think our journey at Peter Mac is probably very reminiscent of the experiences that, as you say, are happening all over the world in the last sort of 5 years or so. And it really came about because of the growing recognition that there's this increasing cohort of patients, whether they be high risk because of their comorbidity profile or high risk because of the surgery that they're contemplating, or potentially both, for which the decision to embark on a surgical journey is not necessarily an easy one. During that kind of process, we realised when we were taking stock of our perioperative processes and our prehabilitation programs that we wanted to really make sure that there was a process or a pathway for which we could provide a safety net for both patients and for clinicians. And the idea of this safety net was to try and make sure that we were trying to minimise decisional regret related to surgery in a high-risk patient cohort, and then also trying to then address aspects for the clinician by providing them with support to ensure that the treatment and the surgical options we were providing patients with were goal congruent. So we're actually, providing patients with an outcome that it would be desired, and also to make sure that there were appropriate processes around contingency planning. So what we would do if surgery didn't go so well for these patients, which in a high-risk cohort is something that is not necessarily unexpected. So because of that, and that sort of growing recognition that is certainly not unique to Peter Mac, when I began my consultant career there sort of 4 or 5 years ago, I was sort of volunteer/told that I was going to be in charge of looking at how to integrate advanced care planning, or I think sometimes, in other circles it's called advanced directives or living wills or a whole other lot of nomenclature. But I was voluntold that I was going to be looking at integrating that into the pre-anaesthetic process. And in my work and research and, all the various kind of quality improvement projects I did around it, I began to realise that actually what we were asking for or what we needed wasn't necessarily just advanced care planning and isolation, but it really spoke to a larger issue of shared decision making. And so because of that, we then have now managed to formalise a shared decision-making pathway here. And again, like I said, elements of this pop up in institutions all around, but I think potentially we've been one of the few places, certainly that I'm aware of within Australia, that's managed to kind of formalise or operationalise the process a little bit more formally. And would it be helpful if I kind of described how that process briefly works for you, Desiree?
I think so, yeah. I think that would be great. Yeah.
So we have, various kind of triage tools, which is tricky, and Ashland and I have discussed that before. But we have referrals mainly for high-risk patients who are having major surgery and also fulfill a certain number of sort of high-risk patient criteria. And then they come to us at a shared decision-making clinic, and they usually have around an average of sort of 2 to 3 visits to see us in the clinic scenario. And there's sort of kind of 3, not discrete, but there's sort of 3 phases that we tend to guide these patients through. And the first phase is really sort of what we like to term an information gathering phase, which is really where we try and take stock with the patient of, what their lived experience so far is of their, index disease or index cancer. We try and find out a little bit more about their values and goals, both related to sort of the treatment decision that's confronting them, and also to do with sort of what their intermediate and long-term goals are for the future. And we take that kind of patient voice from the first clinic meeting we have, and we take that to a shared decision-making multidisciplinary team meeting at which the patients are not present. We all know what MDTs are, but what we've tried to really do with kind of labelling this as shared decision-making MDT is we try and invite a whole bunch of sort of clinicians who are experts in their various fields to give us kind of a way of really coming together to form a unified voice about what we think the potential functional outcomes and might be for this particular patient. So we really talk through what the best case, worst case, and most likely case might be for the various surgical and non-surgical options for this patient. we come together and we sort of build a sort of narrative for the patient that integrates sort of a more narrative picture of risk rather than just numerical risk. And then we then take that narrative risk prediction or functional sort of story, and then we then bring that back to the patient in a follow-up clinic where we talk them through various illness trajectories, functional outcomes, and then we sort of help to provide a recommendation that integrates what the patients have told us in their first visit with the recommendation from the MDT process.
Wow, that's a great example.
Kind of how it all works together.
Yeah, yeah. No, that is a great process that I think a lot of people actually listening would be able to, help guide them. I know there are a lot of multidisciplinary teams, especially in the cancer world and things like that. But really bringing that shared decision piece in is important. Can you tell us a little bit about the education that you do for your patients on shared?
Yeah. For sure. And I think that was one of the big things was really about how do we increase engagement in shared decision making? Because I think there was, as you've pointed out, Desiree, there really is kind of, a growing wave of interest in shared decision making. And we really wanted to make sure people were being engaged in the right way. And we kind of came up with a two-pronged attack in a sense, in that we felt that we needed to engage patients, and we also needed to engage clinicians because I think although there was, a real kind of need, a growing need for it, people weren't really clear exactly on what it was or what we were planning to deliver. So we, through these two processes of engagement, we tried to kind of really give a sense of what shared decision making really is. And so for the patient side of the engagement, we produced or we partnered with the Royal College of Anaesthetists in the United Kingdom to produce an animated patient education film that sort of guides us through a fictional story of a patient facing potentially high-risk surgery and what his outcomes look like, or what his decision-making processes were, either with and without shared decision-making in place. And then from the clinician engagement side of things, as Pragya and Ashland were talking about, communication really is at the core of shared decision making. And although there's a lot of focus in the literature about sort of content and the kinds of things that we need to talk about with patients in order to, to be considered a shared decision making process, there really was a much sort of a much lesser degree of kind of attention given to the process of or how we actually say these things, which is equally, if not arguably, more important than the content. And so because of that, we came together and produced workshops that are essentially small group experiential workshops that work around tailored perioperative scenarios to really give clinicians the chance to identify the skills they already have that are working well in shared decision making, and then to kind of take them to the next level and give them individualized skills that they can take back to kind of aid them in shared decision making encounters in their own institutions. So it's that two-pronged patient and clinician engagement process. This is really the education.
Yeah. Now, typical patients that you are dealing with whenever you are talking about shared decision making, I know that you said, increased comorbidities, increased, risks and things like that. Ashland, I'd like you to join in here. I assume Deb was saying with those different things that we're talking about elderly and frail patients. What is your idea with this? Because there's a lot of issues surrounding, the communication process, how we deal with some of those comorbidities such as delirium and things like that. So from your perspective as a geriatrician, does shared decision making really make sense for that particular patient population?
Well, I think it's, for all its perceived faults, it's certainly better than the alternatives, really, isn't it?
Yeah.
And I think when we're talking about shared decision making, there's a lot of focus, and Deb has obviously spoken about the shared decision making for elective surgical patients, but I think John will probably touch on this later, but I think we need to also think about how it might be used in the emergency surgical setting too, because I think we spend so much time talking about elective surgery, which is relatively lower risk, when actually the most people who die and people who have most complications are older people who undergo emergency surgery. And I think that we need to bring some of the conversations back to that. So certainly obviously I'm speaking of my biases as a geriatrician, so, I'll fly the geriatrician flag, but I think that it's really important to consider, like, we've been really good at thinking about comorbidities and how they affect perioperative risk. But one of the things we haven't spoken so much about is about the geriatric syndromes. And those are things like frailty and cognitive impairment. And I think for older people, they often contribute to poor perioperative outcomes almost independent or in addition to comorbidities. And I think that, frailty's received an awful lot of attention in the literature, probably because it's so easy to measure in many ways, although it seems hard to measure given that there's about 60 different frailty measurement tools. But we don't often talk about cognitive impairments. And I think when we're talking about shared decision-making, you actually need to know about your patient's cognitive function in order to be able to tailor a shared decision-making discussion with them and or with their family members as needed. So if you look at the literature, about 1 in 4 people who undergo elective joint arthroplasty, or probably more like 2/3 of people undergoing vascular surgery or emergency surgery, actually have cognitive impairment. And we know from Jude Partridge's work that actually about 9 in 10 of those are not known about. So we have this huge chasm between what we think is around in terms of patients' cognition and what the reality is. And then on top of that, as Ross mentioned, I work at Logan Hospital. So if you could take Peter MacCallum Cancer Centre and my hospital, they're probably the 2 most different hospitals in all of Australia. My hospital is halfway between Brisbane and the Gold Coast. And Ross mentioned it is in an area that's considered low socioeconomic status, but actually it's a really interesting place to work because we have a really diverse, culturally and linguistically diverse population. So if you're looking at shared decision-making there, so you have people who are possibly older, who might come from a non-English speaking background or have other cultural backgrounds to you. And then in my area, we actually have a lot of people who can't read or write. So if you look at a lot of the cognitive screening tests, they assume that you can read or write, but actually a lot of people can't, and they won't tell you that.
Yeah.
And so I think the reason that's important in shared decision-making is that if you don't kind of frame your discussions, including that, if you don't know these things about your patients, then how can you actually talk about what's important to them and what their values are? And so I certainly think that for most of the older people I see, and I see only our hospital is very much a generalist kind of, we do a little bit of everything hospital. 50% of our work is emergency, 50% is elective, and we do colorectal, general surgery, orthopedics. So nothing out there, no pelvic obliterations or any major cardiothoracic surgery or anything. But my patients are afraid of losing their independence and becoming a burden. And if you understand that, and if you actually understand where your patient is, i.e., are they frail? Do they have cognitive impairment? And what does that then mean for them? Because that probably means they're at more risk of a post-operative delirium. And we know from Sharon Inouye's work that post-operative delirium really changes people's lives. It's more expensive for a health system. It's life-changing for people. They become more dependent, and they've got a higher risk of having dementia longer term. So for me, these are really important discussions. And then the flip side of all of this is what you do for people who have advanced cognitive impairment and who actually need someone else to make the decision for them, and how do you frame that discussion? And I think that there are a whole lot of things that we kind of are only starting to scratch the surface of.
Yeah, it sounds like those are all very important points that on normal conversations that we're having with our patients, we're not necessarily considering. So those are really great points, but also challenges. So John, I want to bring you into the conversation here and tell us, from your perspective, I'm sure there are, a lot of benefits that you see from shared decision-making, but a lot of challenges as well. So just, pivoting off what Ashland was saying, what are your thoughts on some of the challenges of shared decision-making?
Well, it's a little bit about what Deborah said too. There are sort of 2 clients here. One is the patient and their family, and the other is the surgeon. And I think in in the surgical world, there's basically three types of surgeon. There are those surgeons who don't believe in shared decision making. There are those who believe in shared decision making and think they do it. And there are those who believe in shared decision making and know they don't have the time or the skills to do it. But you have to effectively, if you're going to offer the service to all the patients, you have to engage all three of those groups. And it's a bit of a challenge, I think, for that to happen. And I totally agree with what Ashling said about the emergent group. There's no question that the time frame for decision making is shorter, but they are the group that really are most at risk of very bad outcomes, and there's often not so much time to consider it. And I think shared decision making should involve that group if it's really to maximize the benefit of that process.
Yeah. Well, John, you said that there's different types of surgeons and, everybody comes from a different perspective there. How do we get buy-in, from the surgeon group to, really get on board with this idea and implementing it for their patients?
Well, the truth about surgeons is that they are they do have a pretty evidence-based approach to things mostly. So you show them the data that it makes a difference to outcomes, and the majority of them will take it on board in one way, shape, or form. And I guess that's a little bit of what Pragi is trying to do, to give us some evidence to show that it actually does make a difference.
Yeah. Well, how about the idea of team-based shared decision makings and bringing other opinions in? Is that something that you think that surgeons are starting to embrace a little bit more?
Well, it's not really part of surgical philosophy in a strongly embedded way, but I think, look, there is an increasing recognition of the importance of, really understanding the broad impacts of surgery, and that the surgeon can't really be in charge of all of that. Mm-hmm. I think selling that widely will require a proper evidence base, though.
Mm-hmm. I hear. Well, John, can you tell us about this covenant of care? I know that was something that we wanted to touch upon, and that's that you've been dealing with. So can you tell us a little bit more about that?
No, because I don't know that terminology. Somebody else will have to talk to that.
I might be able to jump in there, Desiree.
Oh, sorry. Deb, is that something that you've developed?
It's certainly not something I've developed, but it's certainly something that I reference sometimes, specifically within that realm of kind of surgical buy-in and how do we engage surgeons, or maybe more along the lines of, potentially barriers to surgical buy-in, because I think, it's very easy, for people to fall into their little perioperative kind of craft groups and tribes, and it becomes sort of an us and them, and we do shared decision making and these people don't allow it to happen. And I think in order to kind of really come together and do shared decision making, we have to understand that the barriers that different clinicians face in trying to implement it on the ground with their patients, because if it was such an easy process, we would all be doing it all the time. And the fact that we're all struggling with the same questions in how to operationalize it and how to study it and how to work out what the right outcome measures, just really speaks to the fact that it is a difficult and complex thing. And it's also, it looks very different in each hospital that you're in, because it has to reflect the needs of your patient cohort and your and the clinicians who are providing the various services within the hospital. And so this idea of kind of the surgical covenant comes up. And the idea, it was sort of a term that came, I think, around in the early 2000s or so, and it sort of refers to this idea of this sort of bi-directional contract between the surgeon and the patient, where the patient, by some sort of consenting to a surgical process to happen, the patient allows the surgeon to perform a procedure on their body, so they're sort of yielding control to the surgeon. But in return, there is an implicit promise that the surgeon will look after them and do everything that they can to produce a good outcome. And I think that, it's not just something that applies to surgeons. It probably, to varying degrees applies to, a whole load of, specialty craft groups. And that fact that the closer you are to the patient and the more you feel responsible for their outcome, the harder it can be to sometimes step back and have true clinical equipoise about the various treatment options that you're offering, and to step away from that. So it's kind of, I think, and I'm sure there are obviously various limitations in the kind of theory, but it's certainly something that helps us to understand where our colleagues might be coming from, and the barriers that we can help to address to kind of, normalize shared decision making.
Yeah, that's great terminology. I hadn't heard that before, and it makes perfect sense now, but for sure. Well, we've touched on this just a little bit, but, I think the big question is, do all patients, do we need to be having these conversations with every patient? And I would say that probably have to have some sort of conversation with, obviously we're having those about risk and benefits, but do we need to do a true shared decision model with every patient, make that a standard of care? Ashland, from your perspective and, your patient population, what do you believe there?
I think that, you have to be really careful because it's about resources. So I certainly think that even the 95-year-old person from a nursing home having a small skin cancer removed does not need to see a perioperative geriatrician, but perhaps someone who's 80 who is having a low anterior resection would probably benefit. And I think that's probably where, some of the stuff that is being done around screening for geriatric syndromes, I think that we need to define a little bit better about who will benefit most from shared decision making, because I think we don't know. We keep talking about risk, but is that risk of the medical complications? Because most of my patients don't actually care that much about the postoperative pneumonia. They kind of get an extra day or two of antibiotics and they're fine. Sure, some of them end up quite unwell, but if we need to start picking out people who we think are, going to end up with the outcome of their surgery is not what they expected it to be. And those are the people who will benefit most from shared decision making. And how do we pick that preoperatively? So I certainly think that there's a role for screening for geriatric syndromes. That's been recommended by the American College of Surgeons in their 2019 geriatric verification program. The challenge with that is that we don't actually have the evidence to back up saying that screening plus then what will result, which is generally comprehensive geriatric assessment, either improves outcomes or is cost effective. So I think there's a huge amount of work that's still to be done in that setting.
And John, what about you? What do you think?
Well, it's not practical for every person consenting to an elective or an emergent procedure to go through the full gamut of what we've discussed as shared decision making. But the reality is, at the very simplest end, everybody who consents to an operation, there's some element of shared decision making, but it's not the full range of the process that we've been talking about today. Go on, Deborah.
Oh, no, that's right. I was really just going to reinforce 100% what you've just said, which is that, and echoes of what Ashling said as well, which is that I would agree that not all patients need, nor do we have the resources to supply fully operationalized shared decision-making to every single patient. But I think the key things are that the skills and the elements of shared decision-making, things like, eliciting a shared agenda early, all those communication skills that become, hand in hand with shared decision making are all things that that should be applied to sort of every patient encounter, and are really just, elements of good medicine. It's yes. There's always these parallels with things like, ERAS. Yes. Like there's ERAS and as a package of care, and shared decision making is similarly a package of different kinds of care, but each single element in there is just part of good holistic patient care. So although not every patient needs formalized shared decision making, elements of that should be applied to the care of all of our patients.
Yeah, and I completely agree. I mean, there are certainly plenty of my colleagues who are good enough at being doctors to allow their patients to be involved in a shared decision-making process outside of any sort of formal defined arrangement, and have done that all their lives by virtue of just being good physicians.
Yeah, absolutely. But, you know, then comes the question, how is I guess the skill level of clinicians to be able to implement shared decision making, because obviously you guys are, you know, familiar with all the terminology and know it. And Ashton, I loved what you said about, you know, you have to know the background of your patient and, you know, can they read or write and things like that. Those are really important. But, you know, from your perspective, you know, can all clinicians deliver shared decision making, and do they want to? And I think we've addressed some of those issues. So Pragya, I know, I'm sorry you feel a little left out at this point, but I'm sure you have strong opinions about all these things too, since you are diving into research around it. So tell us a little bit more about what you're doing and a look at a real world approach to implementation of shared decision making, and hopefully adding to the lack of evidence right now.
So in terms of what we're doing, we're basically trying to implement a shared decision-making MDT model into our perioperative care. We're doing a randomized control trial and looking at the outcomes that we think are important both to the patient and to the surgeons and to the hospital, looking at the outcomes that are actually important to tell us if shared decision-making actually works. Shared decision-making has been around a long time, but I think it's quite new in the perioperative arena, and there's some evidence there, but I think like anything, before we throw all these resources at it, we really need to know, firstly, does it actually do what we think it's doing? But also, are there any risks to it? One of the things that I've noticed in the literature is a lot of things are saying, well, patients who go through a shared decision-making model may be less likely to undergo an intervention. And I think Deb may have touched on this earlier. What I'd like to know more about, for example, is, does that actually create extra risk for the patient? Does it mean that by not undergoing an intervention, they're actually turning up to their GP every week or turning up to ED every week with ongoing pain that didn't get treated? So we'll be following up our patients for a year after their intervention so that we can try and get a good sense of how did that shared decision-making process affect not only the shared decision-making process, how did it affect their decision-making, how did it affect their treatment trajectory, what did they choose, and then actually look at some patient-centered outcomes and also look at the economics of it. What does it actually mean for the hospital?
Yeah. So I guess there's a couple concepts that I think that would be good to cover. So, you know, pertinent to the shared decision-making models and the research that you're doing. So I think a couple points is, you know, what is the problem that we're trying to fix with the research that you're doing? And is there evidence that what shared decision-making will do to fix the problem? So can you speak to a little bit of those things and see if we can't flesh out that a little bit?
I think in terms of the problem that we're trying to fix with shared decision-making, it's almost a whole another can of worms, because it's looking at, really it's asking the question, are we doing informed consent properly as both as surgeons and anaesthetists and physicians? Are we actually doing that process properly? And I think that's probably a whole nother conversation. Yeah. In terms of whether shared decision-making will fix that problem, there's some evidence starting to emerge in the perioperative arena, but at the moment, what it tells us is quite limited, partly because of what came up before about what's being called shared decision-making. So like I said, a lot of the intervention studies talk about, well, we gave patients a video and we gave them a decision tool. So there's a lot of variety in what's being called shared decision-making. And then the outcomes that are actually being reported on, John mentioned earlier that surgeons will need patient outcomes in order to change behaviour, and as yet we've yet to see those outcomes formally reported on in a way that will convince people to change their practice. Because really we're asking people to change something quite personal, saying to somebody, saying to an experienced clinician, we want you to change your entire communication style. It's actually a big thing. It's a very personal thing. So there will need to be convincing evidence that it's good for the patient long term. And then that brings me to the third thing is the time that patients are followed up for. There's limited evidence that there is long-term benefit to the patient. So I think that's where the evidence needs to grow.
Mm-hmm. So we
Could I
need
pick
better.
up on
Yeah, absolutely,
on a couple of things, because I think Prague has done such a brilliant job of kind of highlighting some of the issues that her research is going to address. And I think there are a couple of really important things I wanted to expand on from what she said. And I think one of them is that, aside from the issue of, are we obtaining true informed consent for our patients, I think it speaks to a bigger issue as well, which is this idea of patient engagement in the decision, like how, active are they as partners in the decision-making process with their clinicians. And I think it's not just, there's kind of obviously the lovely, airy-fairy ethical imperative that we're doing the right thing of engaging patients. But actually, if you want to get down to sort of like the science and the real delivery of medicine, if you have better engaged patients, then you get better clinical, like hard clinical outcomes. Like there's a lot of data to show that good communication does things like reduce improve blood sugar control in diabetic patients. So we know that apart from just being a nice process that makes patients, fully informed, that if we have a robust decision-making process, we engage patients better, they're more likely to engage in the prehabilitation program. They're more likely to do the structured exercise programs that we give them because they can see real value in it. They have a real concrete goal that they want to get into. So I think that is another really big benefit of shared decision making that the research is yet to really delve into, and that's certainly something that I think is going to be an area of interest. And the second thing that I wanted to talk about was Prague's really insightful comment about communication as being at sort of the core of people's sense of self, and how asking clinicians who have been doing, as John mentioned, such a wonderful job of caring for their patients for such a long time and challenging sort of their paradigms of how they deliver decision making is something that is going to be very challenging. But I think, one really sort of important aspect to rolling out shared decision making is making sure that we're not sort of steamrolling clinicians and saying you must change your style to match, shared decision making as I envision it. It's more about taking the really good, positive things, the great communication skills, the great relationship, rapport building, all those things that you already do with your patients really well, retaining that, and then just giving you those skills to take it up, one or two notches every single time, so it's not sort of steamrolling, it's really kind of taking the good and making it better.
Yeah, no, agree. Well, one of the points oh yeah, go ahead.
I think the upshot of the evidence that I'm hoping the study Prague has instituted will give us is the surgeons will have two responses to this, and one of them will be, oh God, I got to go and learn how to talk differently. And there'll be those who will go off and learn how to talk differently. But the other thing that will happen is they'll say, oh God, okay, so it works. I'm just going to outsource it.
Yeah.
You guys can do it. And that's fine too. The product's the same, the outcome's the same. And if you don't feel that you can invest the time, effort, and energy in learning a different communication style, as long as you can outsource it and the benefits are there, who cares?
Yeah. Ashland, did you want to speak to that?
Yeah, I think John's right. I think the elephant in the room is, as well as which patients benefit from shared decision making, is do all of us need to be skilled at doing it, especially in the really complex situations? And I think John's point is really valid that not everyone does. I think there are some benefits from surgeons, and John North and his colleagues from the Audits of Surgical Mortality published a wonderful paper in the British Journal of Surgery looking at decision regret. And one of the consistent themes that came up for surgeons in that was that they didn't have all of the information, and that they felt that the communication that they had, they didn't have a team around them, and they felt a lot of regret around decisions. And these are patients who have died. So the audits just look at patients who had died. So I think if nothing else, sometimes the role of shared decision making, while we talk about its benefits for the patients, it actually may benefit surgeons in helping them say no when they feel that that's the right decision, or when non-surgical treatment may be the better option. And that's certainly what I see my role as a clinician in my preoperative clinic is.
Yeah. And Ashley and I were talking about the fact that, shared decision making is about sort of, trying to make sure that the sole responsibility for decision making doesn't lie on any particular person, whether it be the patient or the surgeon or the anaesthetist, that it's really this idea of this collaborative, shouldering of responsibility.
Yeah.
And that's where the safety is.
Yeah. Ross, you wanted to make a point.
Yeah. Well, Prague has been shut out of the conversation for a little while, but in terms of this thing of, is there a problem? I think there's all those hard medical issues that we're tracking. And certainly in our country, there are questions at the health service level as well, because, they're, statistically, but I think just in the community, just talking to people, and even, in Australia and I know around the world, the discussion about euthanasia, underlying that is a whole lot of this decisional regret that's out there, and seeing Ashland's type of patients, seeing their friends going through things and saying, oh my God, I wish they hadn't gone through with that intervention, or the people themselves saying that. And that's underlying, that there is a big problem there that we need to address. And I think this is definitely the way forward, but we need to do the research.
Yeah, absolutely. Well, and Pragya, to that, to one of the things that I want to ask you before we close here is that, we have the option of like what you go forward with surgery. So if you're talking to the patient, you go forward with surgery, you outline all the different things that can happen, but coming up with alternatives to surgery. How is that factoring into the research that you're doing? Because I think, it's easier to talk about, well, this may happen if you have surgery, but it's a lot harder to have the conversation about, well, what's going to happen if you don't have surgery?
So that's one of the reasons that I've set up our MDT for our intervention group in the way that I have. So there will always be a surgeon as part of that MDT, and they will be in close communication with the patient's own surgeon, or it will be the patient's own surgeon. And the idea would be that they'll have had all those conversations. They will go to any MDTs that that patient has with their oncology clinicians. So we would have explored all of the different options that are available to the patient. Because I know that in my personal practice, one of the big limitations that I find, one of the big difficulties that I have is that exact thing. I can tell a patient all about their risks of undergoing surgery and having an anaesthetic, but I really don't feel comfortable telling them what's going to happen if they don't have surgery. So I think it's really important that there's someone in the room that can talk to that.
Yeah. Ashland, do you want to add to that?
I was going to say, this is where your friendly geriatrician comes in. I actually find that for patients that I see in my clinic who elect not to have surgery, it probably takes me 4 to 5 times longer to organize things afterwards, especially making sure that they have appropriate follow-up. And I think any discussion, especially say cancer surgery, I've had someone recently who had really severe medical issues, cognitive issues, was frail and had a near obstructing cancer, who elected themselves they really didn't want an operation. But that involved a discussion about what happens when you obstruct. Is a stent an option? Is radiation an option? You should see a palliative physician. You should see a dietitian to make sure you've got a low residue diet. So I think that one of the things that physicians, and I speak very much from a geriatrician bent, but those of us who are generalist physicians, so general and acute medicine specialists and geriatricians, we deal with all of this kind of thing all the time. So many of us have experience in that.
Yeah. All right. Well, we're running out of time today. Thank you so much for this fantastic conversation. We didn't get to chat much about it, but Deb, I've seen an amazing video that kind of walks a patient experience and great for patients and families. Can you tell us just quickly about this, and we can attach it to the podcast. So we'll put it in the show notes, and we'll put it with the vodcast as well, so people can watch that. We'll signpost it to them, but just briefly mention that, because I think it's a really great resource.
Yeah, so it's a resource that we developed. I mentioned it briefly at the start, but it's an animated film that sort of comes off the back of the Royal College of Anaesthetists in the UK did through their pathway to better surgical care, did a video following a fictional patient, Doug, who has cancer surgery. And we really took that same patient and that same story and tried to sort of almost compare and contrast two different approaches to his care. One where he follows sort of what has traditionally been the standard model of care, where there's sort of this, sort of best interest model of decision making. And then another pathway where he undergoes a more comprehensive shared decision-making pathway, as we've discussed, with sort of a prehabilitation program built in there as well. And the idea behind that, as I said, was to really kind of build patient engagement, and also to really prepare patients before they kind of come and see us in shared decision-making, so that they really understand what the purpose of their visit and what the pathway is, and also to help prepare them mentally so they can arm themselves with questions and really sort of start framing things within their head about the kinds of things that they want to discuss in terms of goals of treatment and ceilings of intervention that they're interested in, and really what they're looking for out of a medical treatment process. Great. So that's really kind of where why we made it.
That's great. Can anyone use this video, or what is the copyright on it? And it's free for anybody to see, right?
Yeah, absolutely. So we got it was funded through philanthropic funding through our volunteer service, who do an amazing job and are very insightful in providing funding for these kinds of projects. And it is open source, as you said. It's available on our website, and we'd really love it to be used widely. We purposely chose the animation techniques that we did in order to try and make it as generalizable and as translatable as we could. And so, yeah, we'd love it if people would use it, wherever they think it might be helpful.
Yeah, silly question. They don't have eyes, do they?
Yeah, I know. Actually, it's interesting because I didn't really pick up on that until you said it. And then I looked at it and I thought, no, they don't have eyes. And it's actually, it's kind of weird now that I think about it. But actually, the kind of, it is an intentional decision. Yeah. So it's choice rather than chance. And it's really to do with this idea. I'm not going to pretend to be an expert in animation or educational film principles or anything like that. But my understanding is that there's a couple of reasons for those kinds of stylistic choices. And it's really about keeping the message of the film sort of clean, and weeding out sort of any extraneous detail that may either distract people or make people think, I don't have a beard, so I'm not like that guy in the film. That's not me. So it's really about taking out all that extraneous detail that's going to take away from the core message of the film. So that's why they don't have a lot of detail, and you'll see that the background of the video doesn't really. There's not a lot of stuff. It's quite a plain background. The text is quite plain. All those sorts of things. So it's all sort of stylistic things to make sure that the message isn't lost.
Well, it's great that was intent, that there is intention for all those things, because again, as everyone has talked about today, the patient populations that we're dealing with, we need to be very sensitive to those things. So I think it's absolutely fantastic. Well, everyone, thank you so much for joining in this conversation. It was a great roundtable. Hopefully we can do it again as it progresses and hear a little more about Pragya's research and how that's going along the way, and outcomes for that, because I think everyone's really excited to get some more evidence to support what we believe is probably the right thing to do. But I think it's important to have that. So thank you again. Good luck in all that you're doing. John, I hope you have a very successful culinary career. And to all you guys, good luck in all your endeavors. So thank you very much. Ross, that's an amazing panel roundtable you put together here, and have some amazing colleagues down in Australia.
Yep. And sooner or later we'll meet face to face. But
absolutely.
It won't be for a year or so.
I know.
Yep.
Bummer, but hopefully I'll make it down there. We'll do some more in-person roundtables in Australia in the coming years. So thank you again. Thanks for listening to Top Med Talk. You can check us out at topmedtalk.com. We're on all your favorite social media platforms. I'm going to be coming to you with all kinds of great stuff during EBPOM Live from London and throughout the year. So thanks so much for listening and have a great day.
Top Med Talk.